Okay, good morning, everybody. Today's going to be the last bit of material that'll be on your midterm next Thursday. I was going to get started on some of the stuff, and just kind of introduction to what would be on your second midterm, but I'd rather you guys just had time this morning either to ask questions, if you had them, or even just take a few minutes just to kind of catch your breath and study a little bit rather than jumping into the new material. So today's lecture is going to be a little bit shorter than I kind of expected, but it actually works out for the best in the end. When we meet next Thursday, I'll bring scratch paper for you guys. I know in your ExamSoft computer program they have calculators that are built into it, but if you feel more comfortable with your own calculator, kind of whatever you want to do. There's not a gazillion calculations or anything on there, but sometimes just having scratch paper it makes things a little bit easier for you. So you'll have ample access to that kind of as we go forward. Does anybody have any specific questions before we get started? Okay. All right. So where we left off last time, we had just kind of gone through the refractive. Yeah. Hey.
Do you think that you could possibly post us some practice problems?
I can. I can see what I have available, but I also have to finish your exam too. So I'll just make them the same and change a couple numbers. That's an option. I could totally do it. Let me do this. So maybe because I want to give you guys time in case you did have questions. Like, you're more than welcome to email me over the weekend, but I'll try to hopefully have something posted maybe tomorrow afternoon. It's not going to be 5,000 questions, but 5 or 10 might be helpful just to kind of get you guys going. So I'll do that. The other thing, and this is kind of not last minute, but just to kind of if you guys also want to get some extra help with problems, in the library on reserve, there's the Essentials of Low Vision Practice by Richard Brilliant. He wrote a textbook. It's a gazillion pages long, but at the end of every chapter, there are some practice problems on that too. So not questions that I've written, but just kind of other obviously because he wrote it while I was a student, but that would be another way to kind of test yourself as well, just another access. Unfortunately, there's just not a ton of low vision textbooks that are out there that have a lot of good ways to test yourself as you're going through. So I can provide some of those questions for you. They will not be the ones that are on your test. Hopefully I can make sure I remember not do that, put them on both spots, but at least I'll give you something to kind of answer to kind of as you go forward. Does that sound good?
Thank you.
Sure. Any other questions? Okay, so we'll get started with today. Last time when we got together, we talked a little bit about doing trial frame refraction, and kind of the reason why we do that is we want to get our patients best visual acuity and best visual function. Other things that we kind of consider, we talked a little bit about chair skills and kind of binocularity and kind of how the eyes work as a team. And it is an important feature when we're prescribing low vision devices, or kind of how our patients function. A lot of our patients will kind of, especially somebody who has monocular visual acuity, maybe they've lost vision in one eye from trauma, detachment, or some sort of situation where the vision's very asymmetric. They worry that there's no binocularity or their eyes aren't working as a team. And it is kind of a concern that some patients have, that they only have one eye functioning, and how does that change their visual function? So kind of conversing with patients about their level of binocularity, or what we call, I usually kind of refer to patients as eye teaming skills, or how your eyes work as a team, just to kind of make sure they understand kind of how that goes along. With binocular summation, if both eyes are working well and they're working together, then you may have an overall better acuity with both eyes together. So you might get a summation of improvement of visual acuity when you have good binocularity with your patients. Your fields may be enhanced as well. Your peripheral vision as well as your central vision may be enhanced as well with binocularity, as well as contrast sensitivity. We're going to talk about that in a few weeks, about contrast testing and kind of what that means towards the quality of vision. Of course, also makes sense too that your patients with good binocular vision are also going to have better depth perception. Some of our patients with acquired vision loss sometimes have a harder time traveling up and down stairs, or kind of going in unfamiliar areas. Just even an uneven sidewalk can be a big challenge for somebody who's lost visual ability. So having good depth perception at least puts them at a baseline of having a better opportunity to travel safely and kind of do different types of tasks. The last thing we do is when we get into after your midterm, we're going to talk about different types of devices to be prescribed. And most of the devices that we prescribe are monocular. A monocular telescope, a handheld magnifier will be used primarily with one eye. But there are devices such as telemicroscopes, microscope glasses, or stronger reading glasses that perform better when you have good binocularity. So after we come back from the midterm, those will be some things we take a look at. But having good binocular vision can help stabilize your eyes for different prescriptions of power. There's a few ways that we kind of check for our patients to look at look at their binocularity. We use a Worth 4-dot test just like you would in your PEDS or your VT sessions. We just use a larger flashlight that has larger buttons on it, just to make sure that it's large enough for the patient to be able to see. We also can use the Maddox rod. We use it in a little bit different fashion than what you do in primary care. What you do is put a red streak in front of the non-dominant eye or the poorer seeing eye. There's a little bit of a difference there. Sometimes patients lose vision in their dominant eye, and that can cause a little bit of difficulty with rivalry or doubling of vision. But what you want to do is put that Maddox rod in the poor functioning eye, and if you're able to elicit even just a little pink streak, then you know that there's at least some vision kind of coming through that, and that'll kind of contribute to a positive sign of some level of binocularity. It's there, it doesn't quantify it, but at least gives you that there's some binocularity present. And the last thing is using the 4-diopter prism test. You put the prism in front of one eye and then rotate while the patient's looking at a target. If you are able to elicit binocularity, then you know both eyes are kind of contributing some level of vision. So there's, again, not a quantification, but at least just gives you a positive or negative signal as to whether or not that patient has any gross binocularity kind of as you're going through prescribing. So these are just a couple quick, easy tests to give you just an idea of whether or not binocularity is present for your patients. Does anybody have any questions about that? Okay, so kind of what everybody's been waiting for, magnification. When we talked way back in the beginning, we talked about all these different tools that we have to help our patients' vision function better. And probably the primary tool that you'll be using for your low vision patients is the concept of using magnification. Patients that have poor vision, if they can't see something, the primary approach a lot of times is just making the image larger. We've cleared up the vision the best we can with glasses prescription, but now we're going to use different types of devices or strategies to make that object bigger. So kind of let's see like how we would approach this kind of in a case example. We have a patient that comes in for low vision. We've refracted them, and we're able to see that they can see 2200 in the right eye and their light perception in the left. So when we're looking at prescribing, we're going to look at the eye with the better visual function. So we're going to look at the right eye first. This patient's goal, kind of through your case history, they gave you that SMART goal, that specific, measurable, attainable, realistic, and timely goal of wanting to be able to see a street sign. And so usually when we have a goal that we want to take a look at, we have a goal that we want to look at specifically. When we have a goal we want to look at specifically, we usually like to at least have like some sort of acuity or some sort of measurement to kind of assign to it. So for street signs, we're going to say that's approximately about the size of like a 2040 size letter or a 2050 size letter. That's just one way that we can kind of use as we're going forward with calculations. When we come back after midterms, we'll show how these calculations kind of work together. Our patient also tells the goal they want to see for distance, and it's more task-specific. They want to spot street signs. So what are we going to prescribe? What are we going to do for this patient? And then as we go over the next few weeks, this is going to be the type of situation that we're looking at. What do we do for this patient to allow them to be able to achieve their goal of being able to see the street sign? So first, to kind of go over a few things, when we do look at devices, and for that patient, we'll probably be looking at a device that will be focusing for far away, a telescope. But we want to wait till after we know what our patient's best visual acuity is. So we always wait till after trial frame refraction and get the patient's best visual potential before we even start looking at devices like magnifiers, telescopes, or those other types of assistive devices. We also want to make sure, too, that when we're prescribing, that we give somebody the best correction possible. An uncorrected refractive error might actually change and kind of throw off your measurements for what you're calculating for what a patient may need to see for distance or to see up close. If somebody's 6 to 7 diopters out of focus, that's going to add to an element of blur, and it's going to throw off some of your measurements when we're doing our calculations as we're going forward. If you're not quite as precise or accurate with your measurements, then your device evaluation, kind of what you're prescribing, you're not going to get the results you're expecting, and it's going to become a bit more laborious and a little bit more involved and more complicated. So we want to make sure that we limit how much frustration you as the practitioner have, and that's why we're going to go over how to make these calculations. But also you want to make sure that you're not fatiguing your patient. By taking a long time doing an evaluation can fatigue your patient maybe a little bit faster. You may not get the results that you're expecting. So we want to make sure that we do everything efficiently and limit frustration. When we look at our evaluation, we've kind of done a few parts of this already. From our case history a couple weeks ago, we looked at our patient's SMART goals. We set a goal. We know what our patients want to work on. Then we did some work. We figured out their best visual acuity and kind of like the status of their vision by doing chair skills or contrast, their visual field. And once we have all those pieces of information together, that's when we're going to calculate the type of power that we're going to need for them to achieve their goals. We'll then look at the types of devices that are available, and that's going to be also when we come back from midterm. And then we evaluate the patient in the exam room to see if these devices and the power that we've selected will indeed help them achieve their goals. So this is kind of the stepwise approach that we kind of look at. We want to know what they want to work on, what their status of their visual abilities are, and then we go forward with device powers as well as selection. And when we look at magnification, there's primary types that we look at for low vision. There's a lot of different kinds of magnification, but for low vision, these are the primary four that we take a look at: relative size magnification, relative distance magnification, angular magnification, and then transverse or lateral magnification. The thing to think about when we make things bigger, it doesn't make things clearer. So it's not uncommon that you make things as big as you can for a patient, and they say, well, I can see it, but it's not clear. And you kind of, as you go forth when you're prescribing your devices, you kind of have to counsel your patients. This is going to allow you to see this object, but it's not going to make things crisp. It's not going to make it clear. It's just going to make it easier to see. So the goal of magnification is just to be able to see it, not to make things clear. That's what your refraction did when we started off in the beginning. Up at the top, we look at normal sight, that print text. Everything's normal vision. There's nothing occluding that ability to see that print, so that text is easy to see. In the middle, we can see where that central scotoma kind of falls right over that text, and so it's difficult to see the letters underneath it, and actually it's a bit impossible. You can kind of see the edges of the letters, but you wouldn't be able to know that that word was text unless we had looked at it before. So what we do is kind of in this lowest example here is just by making those letters larger, by magnifying, we're compensating for what that blurry vision from the scotoma has caused, or making it large enough that the retinal image size is large enough to kind of pick up what those letters would be. So this is primarily down here. This is kind of the goal that we're shooting for when we look for magnification. We're making things larger to compensate for the vision loss that a patient has experienced. So let's look back at our different kinds of magnification. Relative size magnification, this is probably one of the most common non-optical approaches to giving patients magnification. You'll hear about the large print Reader's Digest, or if you go to Bed Bath & Beyond, they sell telephones that have those jumbo buttons on them. We also use large print playing cards. What you're doing with relative size magnification is you're just manufacturing something that's new that has a larger image size. So down here in the lower left down here, we have normal size playing cards. By using relative size magnification, we're making the suit larger and making the print larger for that patient to be able to see. So we're increasing the retinal image size by making that actual object larger. Does that make sense for that one? That one's probably one of the more common ones that you're going to run into. And when you kind of are out walking around, you go grocery shopping, you're going to see a lot of different things are printed in a larger size specifically for that. The next thing that we do is we also do relative size or relative distance magnification, and that's just by moving closer to the object of interest. With low vision devices, we're bringing that object closer, and that's either optically with using a microscope, which is pretty common. A patient's own accommodation just by bringing things closer is going to make the retinal image size a bit larger. There's a lot of different devices that we can use that we'll get into after the midterm that we would use to create this type of change in the relative retinal image size by using relative distance magnification. So it's kind of comparing from one distance, that original reference distance, to your new working distance. And that difference in size is going to be your magnification factor there. Lateral transverse magnification, the definition of this is you're looking at your final height of the image reference to the original object size. And it's, again, you're comparing the height of the image to the original object. We do kind of, in low vision, we kind of use it interchangeably with transverse, lateral to transverse. They're not exactly the same, but they're similar enough for the way that we use them with the devices that we've prescribed. One that you can think about is magnification that's produced by a projector. The film of the film negative would have the actual object size, and then it would be projected based on the image. And that magnification would be kind of considered what we'd consider either lateral or transverse. When we get into devices, we're going to look at electronic magnifiers, closed-circuit televisions, as well as stand magnifiers that utilize this type of magnification to help increase the power of those devices. And the last one that we primarily use is apparent angular magnification, and this is what we use with telescopes. With this one, you're looking at the ratio of the image to the ratio of the object size. And that's just pretty much primarily what we use this for, or just using for telescopes or even telemicroscopes. This is probably one of the least common ways that we use magnification in low vision, but that is whenever you're prescribing a telescope, this is the type of magnification primarily that you're getting from that type of device. There may be in some situations where you might want to combine different kinds of magnification, relative size magnification, relative distance magnification. For the people that are sitting in the back row, if they were to move up to the front, that would be relative distance magnification. If I had them move up to the front and made the print larger on the screen, that would be relative size magnification. You compare those two not by adding them, but by making almost a product of those two sources. So if you're to move 10 times closer and make the print 2 times larger, that would be a product of 20. What you have to consider is it's not additive, it's going to be a product. So you're going to get a lot of bang for your buck if you kind of add 2 different types of multiple sources of magnification together. One of the examples I have here is just moving a book 3 times closer. A lot of our patients will prescribe either a higher powered ad or we'll give them a stronger pair of reading glasses, and they move the original 40 centimeter working distance closer. If they were to move 3 times closer and we were to enlarge the print 2 times on that book, it would be a product of 6 times of would be effective magnification for that strategy. A lot of times people think you just add them together. It would not be 5 times, it would be 6. It could be 3 times 2 would equal 6. So sometimes with low vision patients, we do want to give them the best working distance possible. We can combine different factors and different ways to magnify to give them a little bit more magnification altogether. So I know we don't have our clickers back, but just a kind of a quick check-in. Sitting in the front of the classroom compared to the back of the room is an example of what? Relative size magnification, relative distance magnification, transverse magnification, or angular. Who says relative size magnification? Relative distance magnification. Transverse magnification, angular. Good. So just a lot of times, you know, for you guys here, everybody's normally sighted. You also have, in some of the classrooms, there's other screens that are kind of closer to you from the back of the room. But for kids that have visual impairments, a lot of times we'll recommend they sit towards the front of the room. Then that way they get that benefit of the magnification just by sitting in the closer front part of the room. For the devices that we'll be taking a look at, the primary devices that we look at in low vision are a lot of near devices as well as a few distance devices. Microscopes are more like single vision reading glasses. We just call them microscopes to make it confusing, but they are microscopes. Handheld magnifiers are just a device that a patient would use in their hand and kind of hold the device at the focal length to get the benefit of magnification. Stand magnifiers and electronic magnifiers are good devices for prolonged reading. We'll take a look at those in a few weeks. And then our distance and intermediate devices would be telescopes, similar to like a pair of binoculars, but just using one side, or a telemicroscope where it's adapted for an intermediate distance. So these are going to be all the devices that we're looking at over the next few weeks to make sure you guys feel comfortable with being able to prescribe those when you get into clinic. When we look at different types of optical aids evaluations or assistive device evaluation, we kind of break things up into the patient's specific distance that they're working at. And then primarily for distance, the telescopes are the primary device that we use. There are some new electronic devices that are available that can actually focus at a distance. You'll hear about eSight. You might have heard about a Jordy that's available. The reason why you might hear about them is sometimes they talk about them on the news, this new way that's going to improve blindness. But the companies kind of make sure they get out into mainstream as well. Also, to your phone, you can use your camera on your iPhone or your other types of smartphones and use that kind of also as a distance magnification device as well. That's another thing that you can do. For intermediate, the primary device that we use are telemicroscopes as well as electronics. And then for near, that's where we have the widest range of devices available, microscopes, handheld devices, and stands. Electronic devices, you'll hear a lot about closed-circuit televisions. And if you guys are in VT or if you get a chance to kind of rotate through low vision as a third year, for observation, you'll see that there's a lot of portable closed-circuit televisions as well as desk systems. And that's probably the biggest area of growth that's been in low vision over the last 10 to 15 years, are just using electronic devices to kind of compensate for what the optical devices would be able to do for patients. So we'll take a look at that kind of as we go forward through the semester. And these are just a few different devices. My pointer is not working, but in the upper left corner is what we call a loop. It's just a pair of like +3, +4 lens. That's what that bar is just a +3, +4 lens. It clips on the front of a pair of glasses, and it gives you that intermediate distance. In the upper right corner, that's a pair of microscopes. We call them prism half-eyes, but just because the size of the frame is half the size of what a normal frame would be. We have a handheld magnifier, and then as well as a stand magnifier here. Handheld devices, they come in a huge range and huge range of quality, as well as some of them are illuminated down in the lower right corner. This one has a light that's built into it. The others are ones you just throw in your pocket and take with you. Telescopes and telemicroscopes, in Tennessee and some states, we can actually use this device here to get patients who are visually impaired legal to drive. We'll talk about that in a few weeks coming up, but there are devices that we can use that are head-mounted or handheld to get patients to their goal of being able to see distance. And this little guy that just went flying across the bottom there, that's what we used primarily to adapt a telescope to a telemicroscope, just giving a little bit of plus power at the end of the objective lens. Electronic devices, this is, again, probably the biggest area of growth with low vision. There's things that can utilize a patient's own television down here. There are scanners that are available. In the upper top, this guy that's way up here in the middle, there's a camera that's underneath the television that points down on the screen. And then just by making some modifications with the buttons on the front, you can magnify, you can change the contrast. So instead of having a white background, you can have a black background. It flips polarity. There's a lot of different options that you can do, and you have a range of magnification. Optical devices, it offers one level of magnification. Electronic devices offer a range of magnification for our patients. And then we'll also kind of, when we get finished up with all of our optical devices, we'll look at some non-optical strategies, filters. Lighting is very crucial for our patients and kind of how we adapt our patients' environment for reading, utilizing those different strategies. So when we get to device evaluation, it's really difficult initially to know what kind of device to pick from because there are a lot of devices that are out there. You want to kind of go back to your exam and make sure you tailor it for your patient. Any device that you're looking at is going to be specific for your patient. The distance they need to work at, so somebody who's going to be using the computer isn't going to need a distance device. We're going to make sure we have something that fits for that patient needs. Task specifics, that's why we have to have a goal that's really specific and on point to make sure that we have something that's going to fit that patient-specific task. And also the device itself is going to tell us how it's utilized, whether it's not going to be a good fit for our patients. Some of them have problems with tremors or weakness, and that certain devices may not be a good fit for what they need to do. When we look at the distance specific, we're going to break everything down into different distances and figure out how to fit goals or how to meet our patient's goal at different distances. We're also going to look, again, specifically at the patient. Probably one of the main things that we take a look at, the ocular condition itself is going to help dictate when to prescribe a device. We have a lot of patients with wet AMD, and they're getting injections, so you have to consider when it's time to actually prescribe a final device. If a patient's just starting on injections, they still have macular degeneration, but their visual abilities may fluctuate a little bit until they stabilize. So it's good to know that you have somebody that has good stable vision and make sure that they're going to have the level of vision that they have before they go through the investment and training with the device. Other things, physical impairment and limitations, that's a very key thing to kind of take into consideration. Some of our patients, when they come to the exam room, we don't have them do a lot with their arms or hands. So when you do get them to go use a device, you have to make sure they're actually able to physically use it. We had a patient who had a stroke and had no use of their upper arms, but they were prescribed a closed-circuit television by another doctor, but they couldn't use the device, couldn't make any changes to the manipulations of the buttons or the table to actually be able to use the device. So they had a $2,000 device that they could not functionally be able to use just due to different types of physical impairments. So those are some things to kind of keep in mind when you're prescribing. Your patient's preference, to prescribe a lot of devices, one of the main factors it has an impact on is relative distance magnification. So a lot of things you're going to have to get closer to the object of interest to get the benefit of the magnification. So somebody who's using a computer and you're prescribing a pair of reading glasses, you're not going to want to prescribe them a very strong pair, a 20 diopter microscope. They're going to have to be 5 centimeters away from the screen, and that's very difficult for somebody to do for a prolonged period of time. So you might have to work with balancing different types of magnification to be able to get them to their goal where they'd be comfortable for using the computer for a while. And again, look at their current level of vision and then also looking at their SMART goal. Task specific, patients will tell you they want to read. That's such a broad type of task to do. If you go a little bit further, is it going to be spot reading, looking at a medicine bottle or a thermostat, or something that's going to be more prolonged reading kind of going forward? And we're going to also need to see what kind of magnification, and that's going to be where the formulas kind of help us along there. Also device specific, there's the characteristic of the device. Also the cost of the device can be prohibitive for some patients. We know insurances don't cover magnification devices or any type of assistive devices, so that's going to be another thing that might be prohibitive for some of your patients. We'll talk just a couple quick seconds about the formulas that we'll be learning about kind of as we go forward. The formulas are so important. They're usually the bane of low vision's existence. If you ask anybody that's graduated from optometry school what frustrated them the most, a lot of times the low vision calculations can be one of the things that he kind of mentioned really quickly, sometimes a little too quickly. But what we're going to be talking about is kind of the importance of using a formula to calculate a starting point for our device selection that helps make things efficient and makes it more likely to be successful. You also have to consider in mind as you keep going through all of your calculations and you figure out the device, are you still meeting your patient's goal? And that's going to be part of the training and the assessment of our devices kind of as we go forward. The goal is going to, again, come back to your patient. So if you prescribe, a pair of glasses for prolonged reading and you have somebody that doesn't have a goal of maybe reading for a long period of time, your motivation, the patient's activity level, and vocation may change the outcome of that device being prescribed for your patient. You also have to take a look at kind of what your patient's doing throughout the day and kind of make sure that you're going to be able to achieve the goal of what they want to be able to do. When we talked a little bit about kind of different goals patients may have, we like to assign an acuity to different types of tasks they may want to do. So a patient who wants to go to McDonald's and see the print that's on the screen, the menu that's kind of projected back behind the cashiers, that would require about 20/60 visual acuity. Microwaves might require a little bit less acuity just because the buttons are a little bit larger. Different types of tasks are going to be assigned a different acuity level that we can use to at least calculate the goal that we need for our patients. And I'm going to skip over the formulas because we're going to get to that when we come back after your midterm, because I don't want you guys to get so excited about this and not be able to focus on your midterm. So I can see where this is going. But what we'll do is it'll be more appropriate when we get to those sections of your course. So we'll skip over that. Don't even look at it because you will not be able to focus and you will not be able to sleep at night because it's so exciting. So when we look at our devices, we're prescribing our final devices. We're coming down the home stretch. You have the power that's going to be needed for that patient for distance and near. You've calculated your device. It's appropriate. You're going to evaluate that device with your patient. You want to make sure that patient has that device in their hands and they're able to do a task that's going to simulate what their goal would be. You want to also prescribe what that device is going to be based on your patient's performance, how well they do with it. Theoretically, a 10 diopter pair of reading glasses may be perfect for that patient, but when they start to realize they have to hold things 10 centimeters away from their eyes, that may not fly as well with your patient, and they may struggle a little bit. You want to give a device that your patient's going to perform well with, and they're going to be consistently performing well with. So whatever their best performance is, that's what you want to kind of focus on. And also, too, your patient's acceptance. We can spend a lot of times with devices, find solutions for a lot of different things, but if your patient is not accepting of the fact that they need to utilize a device or that they need that help, it can kind of end up with giving a little bit of frustration because they may not actually pursue the device. We had a gentleman in low vision yesterday. He was in his late 80s, had AMD for I think 15 years, had never seen a low vision practitioner before, so he came in to look at devices for reading. That was his primary goal. And he did beautifully with every device we looked at. He was able to use all the electronic devices, even though he wasn't tech savvy, but he did great with them. But when it came down to it, he wasn't really accepting of the fact that he had to use a device. He still wanted his vision to get better. He was in that kind of bargaining stage. If I give you $1 million, can you get my vision back? And, of course, that's not going to work out. The patient, he wasn't accepting of his vision loss and not accepting of the devices. So even though he did well with everything, he just wasn't ready for those types of devices. And we'll kind of check in with him kind of in 6 months and see where he's at that time. So to kind of finalize, kind of like back to our case that we looked at initially, we had our patient who came in seeing 2200, and their goal was to see a street sign far, far away. What we assigned to that type of task was a 2050, and that's pretty universal. What we would do is we'd realize for distance and for spotting, probably the best type of device for that would be a handheld telescope, and we'll talk about telescopes kind of as we go forward. What we calculated it for to be, what I calculated would be what they can see, that 2200 divided by what they want to see, 2050. So 200 divided by 50 is a 4x. So we showed him a 4x telescope, and he was able to achieve all of his goals with that type of telescope. As we go through the next few weeks of the class, these are the types of things that we're going to be taking a look at, what the patient's visual status is, what their goal is, and then figure out what types of devices would help them meet their goals. And that's going to be kind of when we come back from our midterm break. So that's it for now. Does anybody have any questions? All right, so I will see you guys next Thursday. If you have any questions, just shoot me an email.